Good afternoon, Dr. Kent. Thanks for taking a few minutes away from clinic to share some valuable information with our Fibrolamellar community. Can we begin by having you tell us a little bit about yourself and your background?
Hello, my name is Dr. Paul Kent from Rush University Medical Center. I'm 57 years old. I'm an associate professor here. My background is I grew up in Boulder, Colorado. I went to Harvard for medical school. Then I was a teacher overseas. Came back, went to Mayo Clinic for medical school, an internship. University of Chicago for pediatrics and chief residency in pediatrics, and then Northwestern Children's Memorial Hospital to be an oncologist. I first found out and got interested in Fibrolamellar 3.5 years ago when a patient came to me, 4 years almost now, disease I had at that time never heard of, and the patient was so inspiring to me that I made it my mission to learn everything I could about Fibrolamellar. Finding out about Fibrolamellar for the first time after 20-some years in my career, I did a deep dive. I tried to learn everything I can, and that's how I first met Tom Stockwell in FibroFighters. And since then, he has provided me with a wealth of information because, as you know, he's devoted his life in honor of his son to be knowing everything there is to know about Fibrolamellar, and consequently I've learned tremendous amount from him, and it's become my passion as well to learn and continue to advance understanding of Fibrolamellar. I now have a family of 5 children, 4 adopted children. My wife's a pediatrician. I tell everyone that instead of making do no harm as the goal in medicine, which is something you often hear, I use the standard of treat every patient like they were my own child.
Thanks. Now can you tell us the circumstances surrounding your first fibro patient?
Yes, about 5 years ago was my first ever Fibrolamellar patient in 2015, the fall of 2015. A 15-year-old young woman who had had her primary surgery, tumor removed, thankfully no spread or metastatic, and then was offered treatment that with cisplatin and doxorubicin. They asked for a second opinion. They ended up going to MD Anderson, who recommended 5-FU and interferon. They came back and their primary team oncologist didn't agree with that, so they came to me and asked me if I'd be willing to do this treatment in a 15-year-old, and I said yes. So that was the start.
Wonderful. And so since that time, how many patients has FibroFighters and the community referred to you?
Total patients that I've communicated, referred to, talked to, emailed, done lots of video visits and Zooms is 55.
Wow, that's amazing. And that's just over a short, probably last couple of years, right?
Right. The second patient was a year after the first patient, so that would all be in about 4 years' time. And not all of those patients have come here. We've been doing video visits, lots of phone calls and Zoom, as we all know the way things are today. But at least half of them have come here to be seen and had their surgeries here or other interventions here.
So perhaps maybe with one of the sides, as bad as COVID is, but now we're being forced into the telemed world, if you will, I think that might open the playbook up a little bit for Rush, in that now you're going to be able to talk to patients firsthand that way and create that dialogue. And so obviously that's, I think, something with your gained knowledge of Fibrolamellar, I would think that that's going to be an extreme benefit, being able to do it that way, right?
Absolutely. I had never done a video visit until March of 2020, and I think the COVID crisis had a lot of probably physicians my age or in this who had never done it before, who've learned how to do it, and that it turns out to be a great choice for people who don't have to travel. We can show the scans, we can look at the pictures, we can go through the different paradigms, we can talk about chemo, we can look at the different sheets. I can even show them results from other patients. It actually works really well. In some ways it's even better than sitting in a conference room with a bunch of papers, because we can talk through everything. We can even necessarily Google something and share it online. So it's been I think helped communication tremendously in my world.
That's excellent. So the other thing that I think comes up often, you are classified as a pediatric oncologist. So with that, we have a median age in the Fibrolamellar community, usually between 22 and 25 is probably an average. We've seen our share, of course, of adolescents, there as well. So the question becomes, what do you tell the patients that maybe say, well, he's a pediatric oncologist, we're not going to call him, we're not going to go there because we're 29 years old or we're past this. So can you explain a little bit about how that works?
Yeah, so for my patients, the median age is 19. We have patients from age 6 to 56. But a whole bunch of patients clustered right around 18, 19, 20, 21, 22, a lot, probably 20 just in that range. So number one. Number two is that to me, is still a pediatric cancer. It's not a cancer that is from exposures, from the environment. It's something that probably started early on, maybe even in utero, like a lot of pediatric cancers, and at some point in your life manifests, as opposed to hepatocellular carcinoma, which we know is from exposures and damage to the liver, hepatitis C, hepatitis B, alcoholism, any number of other injuries. And that paradigm is something that we're much more used to. We're used to treating young, healthy people who can and should get the most aggressive possible treatment. It's now recognized that young adults with cancer, meaning age 15 to 39, don't do as well because they don't get aggressive enough treatment. They're typically treated in a more sort of palliative approach, probably because the majority of the doctors in adult oncology are taking care of older patients who are sicker. And that's not true for our patients. They're young and healthy, they're not sick, their kidneys work, their livers work, their heart works, they don't have diabetes or hypertension, most of them aren't smokers, they don't drink. And therefore, you can and should be very aggressive and do everything you can to cure them, which is our step one. When I talk to patients in pediatric oncology, I say we have three main goals for the care of your patient: to cure them, to cure them, and to cure them. I don't say quality of life and side effects, although I care about that. I'm not for a second going to pretend that that's as important as trying to cure them. And if that's not the philosophy they want, of course, that's fine. But that's our philosophy.
Well, I think that's the goal, right? I mean, it doesn't get any better than that as a goal. So I know you've been working with many different types of systemic treatment options for this group of patients. Can you tell us, I know the one in particular, there's a triple combo therapy, and then there's this other therapy called Magic Mike, which I really think is an interesting name. And I know that you've been working really hard with your team here, and I'd like you to expand a little bit on that and tell us a little bit about if there's a study planned or where the status is with some of these things, because I really would like if the community could see results and it could be shared with other clinicians, not only in the States, but somebody even, let's say, Australia or the UK, for example. So if you could kind of go down that path a little bit, that'd be great.
Of course. Yeah. So the original first systemic therapy that we really embraced was not created by me. It was actually created by a guy named Howard Simons, who had success with this, working with his with a doctor in Israel and a patient who did well after having many failures and relapses with previous treatment. So that's what was the initial idea. It got then adopted by the MD Anderson team, Dr. Kasib, who's one of the best liver oncologists in the world, and they had a protocol. Unfortunately, it didn't open for various reasons. It didn't open. They couldn't enroll, and this went on and on and on and on for years. I think it's finally going to open. I don't know. Anyway, so I used that protocol as a recipe book, and we followed it. So we were doing the same treatment because people kept coming and saying, I want to do the MD Anderson protocol, but it's not open. And I said, well, I'll do it. We'll just follow it along. even though it isn't at the moment an official open protocol. We ended up having 30 patients like that who were treated. We have about half of those who have more than 9 months, so we can really see if it's working. And we just had a paper published or accepted for publication on those first 15, half of those patients getting that immunotherapy. And it's very exciting, very promising.
Wow, that's excellent. So with that, I guess you would say that's one of the more encouraging ones. But again, probably not everybody, will get a response. So with those, I know telling our FibroFighter community, I like to use the terms plan A, B, and C.
Yeah.
And to have something always ready. Not believing that something might fail, rather than just be prepared and knowing what plan B's and C is going to be. So with that, what is your plan B and C for the patients that might fail the triple combo?
Yeah, the triple immunotherapy combo using nivolumab, interferon, 5-FU, or you can substitute Xeloda for it, is not necessarily my first choice. It's the first choice for people who have a minimal amount of disease, who've already had their surgery, and maybe they're in a surgical remission or there's only a little bit left. That's the time to engage the immune system to hopefully give us long-term protection with the aid of the immune system. For patients who have bulky disease, large tumors, especially so much that it can't do surgery, and we need to shrink it a lot quicker, that would not be my first choice. We use a combination of gemcitabine, oxaliplatin, lenvatinib, and quercetin, four different drugs. Now, each of these have been tried in bits and pieces, but not all together in combination, and there's synergy there that we've seen. And our first 3 patients, all of them, have had tremendous response. 2 of the patients were in hospice, and both ended up getting surgery, and one of them back in college doing great. There's another, and the third patient was supposed to go to a liver transplant. The tumor shrunk so much that now they're just going to, hopefully next month, take out the remaining tumor. We have several others who are just getting started, but so far we're seeing shrinkage with all of them. So that's a special therapy when you have a large amount of disease. We need to move quickly, we need to shrink quickly.
That's great. So it sounds like there's all this great, exciting news happening at Rush. And the big thing in research and in the clinical world now is this word that you hear all the time, and it's called collaboration. And everybody's supposed to be collaborating, but yet very few seem to be doing so. So you're one of the few clinicians that seem to be able to navigate through those obstacles. So number one, obviously you must believe in it, and how do you approach that, and why are you so much more successful than anyone else? Because I'll tell you typically are. So give us the secret.
Well, that's nice of you to say. I don't know if that's true, but I think we all want to collaborate. We understand that nobody knows everything. You have to participate. The GemOx, lenvatinib, quercetin, that paper was a doctor from MD Anderson, a doctor from St. Jude's, a doctor from Georgetown, and me, and then another medical student who helped too. So anyway, from all over, working together, sharing our knowledge, and so on is important. But I think that's among the oncologists. But even more important is the fact that we have a Fibrolamellar tumor board every single week, and we all get together, and we sit in the same room, and we go through the cases. The surgeons, 2 of the best surgeons you're going to find in the world when it comes to fibrolamellar, Dr. Hurdle and Dr. Schade. Interventional radiology, also one of the best interventional radiologists you're ever going to find with Dr. Tassi. We all work together and say, I could do this, and then you do this. Well, this will, if you do this first, and thoracic surgery and pathology, radiation, that's the key, as opposed to having one person making decisions and running with it. You have to hear from everybody and work together, and you have to do it on a regular basis and get to know each other, get to know each other's techniques and strengths. It takes a lot of extra work to have that level of coordination, but it makes a huge difference.
So see, that you brought up an interesting point, is that it starts with collaboration within the team.
Right.
So if it's not there, that's where maybe a lot of these other places it might break down. But you're not only doing it within Rush, but then you're taking it outside of Rush,
right,
and working with other oncologists. And I think that's really important for our Fibrolamellar community to know, that if they live on the West Coast, or they live somewhere in the South or in the Northeast, wherever they are, that if they come to Rush and they talk with you, you're going to work with their local team? Is that what you're saying?
Oh, of course.
Do it? Okay.
Yes, of the 50, well, some of those patients sadly have passed away, but of the 40-some patients that are still fighting fibrolamellar, there's only one that's getting her immune chemotherapy here at Rush, 1 out of 40. There's a second one who's supposed to start soon, but all the rest are getting them. All the other 43 or 44, whatever it is, are getting their therapy at home with their doctors at home. And we form a relationship and we talk and we do Zoom meetings together with the patient in the room where I'm on the TV screen or the computer screen, whatever. I mean, we do whatever we need to do. And we work together. We don't want people, no, we want them getting your care at home. We want you going to school, going to college, going to your job. We don't want you coming back and forth. That makes no sense. We want you right there getting treatment at home nearby with your own team of oncologists.
Wow, very refreshing. That's great. So tell me a little bit, what role do you see the Fibrolamellar project at the Nagurny Cancer Institute playing in assisting with treatment strategies for our FibroFighters?
Yeah, they have been fabulous. The FibroFighters and the Nagurny Institute, they give us a lens into strategies to try. So I have a couple other combinations as well, for example, that I've used. I very strongly believe that you have to treat fibrolamellar with combinations. Never a single agent. Doing sorafenib, terrible idea by itself. Doing even lenvatinib by itself. Doing nivo by itself. You never do any of these by themselves. So how do you look at these combinations? And the cool thing that Nagurny does is they test the patient's own cancer cell against various combinations of drugs, and that gives me tremendous information. It shows where the synergy is. It shows that option B looks better than option C, or maybe option C looks better than option A. It gives us a great insight. And what's fascinating is how the tumors are all different. So you can't necessarily know that one strategy works for one person. So we're finally starting to understand a little bit between the connection of basic science and how the tumor behaves and what the best treatment is.
Well, I got to tell you, thank you so much. It's been wonderful working with you over the last 3 years, and all the people here at Rush. I mean, it's been a tremendous experience. And the feedback that I get from the Fibrolamellar community all basically gives Rush high marks. So that's really saying something. So on behalf of those 55 FibroFighters that Rush has been instrumental in helping, I want to personally thank you from all of them. So Dr. Kent, thank you.
Well, the thanks I want is to know that they are being normal young people living their lives. That's what I want. I want to know that they're going to college, that they're getting married, that they're doing their job, that they're playing with their kids and walking their dog. That's what I want. That's all. That's only thanks I want.
Perfect ending message. Thank you again.
All right.
Back to clinic. Thanks for watching, FibroFighters and caregivers. I hope you found this informal chat to be informative and encouraging. The clinicians like Dr. Kent are dedicated to finding the best possible care and treatment options for our community. I was so awestruck by this photo of a young FibroFighter depicting his strength and defiance of his cancer and being supported by his younger brother in the background. Kemp is one of the now 65 patients being followed by the entire Rush team. Let's work together and slay this fibrolamellar beast.